Hi everyone, our subject today is neonatal jaundice. Jaundice is a yellow discoloration of skin, sclera, and other tissue caused by deposition of bilirubin. The degree of jaundice is related to the serum level of bilirubin and the degree of its deposition into the extravascular tissue. The most common source of bilirubin is the increased breakdown of hemoglobin. Jaundice may lead to kernicterus, which is a neurological syndrome resulting from the deposition of unconjugated indirect bilirubin in the basal ganglia and brainstem nuclei. The toxic blood level for an individual infant is unpredictable, but in general, kernicterus typically occur only in infants with a bilirubin level more than 20 mg per deciliter. Nearly all newborns experience some rise in serum bilirubin level owing to the relative immaturity of their hepatic excretory function. The frequent occurrence of hyperbilirubinemia and jaundice, approximately 1/3 of all newborns develop jaundice, has resulted in the term physiologic jaundice. Levels higher than those used in the definition may occur, exaggerated physiological jaundice, but some evaluation must be done to rule out more serious disorder before making the diagnosis. Breastfed infants have an exaggerated physiologic jaundice in the first week of life, with significantly higher bilirubin levels than formula-fed infants in the first 5 days of life. This is due to decreased calorie intake until adequate breast milk supply is established, with a resulting increase in enterohepatic circulation. Breast milk jaundice is jaundice occurring after the first week of life. The mechanism is not clearly understood. To confirm the diagnosis, breastfeeding may be discontinued for 24 to 48 hours to observe whether a decrease in bilirubin level occurs, but in most cases, mothers should be encouraged to continue breastfeeding. Extravascular blood results in increased bilirubin production. Examples include cephalhematoma, ecchymosis, occult hemorrhage, as well as swallowed maternal blood. Any condition causing obstruction or delayed passage of meconium, like Hirschsprung disease, meconium plug syndrome, will increase enterohepatic circulation of bilirubin, contributing to indirect hyperbilirubinemia and jaundice. Prolonged indirect hyperbilirubinemia may be the earliest clinical manifestation of congenital hypothyroidism as well as hypopituitarism. These may also cause conjugated hyperbilirubinemia. Isoimmune hemolytic disease occurs when maternal antibodies to the erythrocyte of the fetus cross the placenta and cause destruction of the fetal red blood cells. Incompatibility of the Rh factor causes the most severe disease in progressive pregnancies. ABO incompatibility causes less severe hemolysis. On occasion, infants in the latter group will demonstrate a negative or weakly positive direct Coombs test, but the indirect Coombs will be positive. Oxytocin, excess vitamin K in premature infant, some antibiotics like sulfonamide, ceftriaxone, and phenol disinfectant are examples of drugs and toxins that may contribute to unconjugated hyperbilirubinemia. A congenital infection is suggested by intrauterine growth retardation, microcephaly, and ophthalmologic abnormality like cataract, chorioretinitis, posterior embryotoxin. Characteristic phases may suggest syndrome associated with hyperbilirubinemia. Any of the torch infection like toxoplasma, rubella, cytomegalovirus, herpes virus, syphilis may cause growth retardation and cholestasis. Idiopathic neonatal hepatitis is defined as prolonged conjugated hyperbilirubinemia without an obvious etiology after non-infectious and metabolic and genetic causes have been excluded. Biliary atresia is the most common cause of neonatal cholestasis and should be considered in children with conjugated hyperbilirubinemia and elevated GGT. Children are initially asymptomatic at birth and become jaundiced after a few weeks. There may be a colic stool. Evaluation should include an ultrasound to exclude other anatomic abnormality, including choledochal cyst. How to approach to neonate with jaundice after performing history and physical examination. Obtain total, direct, and indirect bilirubin. If it is predominantly direct conjugated hyperbilirubinemia, consider CBC with differential and smear a blood and urine culture. Review newborn screen for hypothyroidism, galactosemia, tyrosinemia, cystic fibrosis, serum glucose, albumin, liver function test, AST, ALT, GGT, alkaline phosphatase, PT, torch titer, VDRL for syphilis, urine for reducing substance, alpha-1 antitrypsin level, and liver ultrasound. Differential diagnosis. Most common cause is infection. So UTI infection, sepsis, congenital infection, idiopathic neonatal hepatitis, obstructive disorder, biliary atresia, choledochal cyst, obstructive cholangiopathies, alpha-1 antitrypsin deficiency, cystic fibrosis, hypothyroidism, hypopituitarism, metabolic disorder like galactosemia, tyrosinemia, genetic syndrome, trisomy 21, Alagille syndrome, and parenteral nutrition. If it is predominantly indirect and conjugated hyperbilirubinemia, is there red flag present like bilirubin level more than 95th percentile for age in hours, onset of jaundice less than 24 hours of age, rapid rise of bilirubin level more than 0.5 mg per deciliter per hour, maternal blood group O, Rh positive, and history and physical examination indicate risk factor. If it is no, patient has not red flag, observe, consider a repeat bilirubin level. Bilirubin is still below 95th percentile. If it is yes, this is physiologic jaundice, breastfeeding jaundice, and breast milk jaundice. If it is elevated or patient has one of these risk factors, consider Coombs test, CBC with the smear, retic count, infant and maternal blood type. Then send for Coombs test. If it is Coombs test positive, differential diagnosis, isoimmune hemolytic disease, Rh, ABO, and other. If Coombs test became negative, send for hematocrit. If high hematocrit, differential diagnosis, polycythemia, diabetic mother, fetal transfusion, delayed cord clamping, intrauterine hypoxia, and small for gestational age. If it is normal hematocrit, send for retic count. If it is elevated retic count, send for hemoglobin electrophoresis, glucose 6-phosphate dehydrogenase, enzyme level. A differential diagnosis, RBC membrane defect, RBC enzyme deficiency like G6PD, and hemoglobinopathy. If it is normal retic count, differential diagnosis, breastfeeding jaundice, breast milk jaundice, physiologic jaundice, extravascular blood infection, sepsis, increased enterohepatic circulation, hypothyroidism, drug toxin, hepatic hyperperfusion, congestive heart failure, metabolic disease, galactosemia, tyrosinemia, familial hyperbilirubinemia syndrome like Gilbert syndrome, Crigler-Najjar syndrome, Lucey-Driscoll syndrome. Note, at 2 weeks of life, up to 15% of newborn are still jaundiced. Jaundice may persist in 9% of breastfed infant at 4 weeks. This jaundice is overwhelming by unconjugated bilirubin. Risk factor, increased RBC mass, breastfeeding, excessive weight loss, male sex, maternal diabetes mellitus, hemolysis, ABO or Rh incompatibility with positive Coombs test, G6PD, gestational age less than 38 weeks, a prior sibling with jaundice, especially if phototherapy was required, Asian ethnicity, coexisting illness like sepsis, hemolysis, and other illness. Top tips. Physiologic jaundice occur in most neonates during the first few days of life. It is not a disease. It is not present in the first 24 hours, and it is always indirect hyperbilirubinemia. Direct reacting bilirubin is water soluble, not fat soluble, and therefore does not damage the brain tissue to the cause kernicterus. It is, however, associated with serious disease such as congenital hepatitis and biliary atresia. In hepatocellular disease, there is a disproportional increase of ALT and AST compared to alkaline phosphatase increase, whereas in cholestatic disease, it is the opposite. ALT is present in the liver, hence more specific than AST, which is present in other organs. Red flags. Always measure serum bilirubin in babies with jaundice in the first 24 hours of life. Children with acute UTI present occasionally with jaundice that may divert attention to hepatic disease, causing delay in antibiotic administration. The infection can progress to septicemia. Be aware that children with biliary atresia are usually healthy looking and indistinguishable from those with the physiologic jaundice during the first 2 weeks. When jaundice lasts more than 2 weeks, always measure direct bilirubin and ask for pale, chalky stool and or dark urine that stain the nappy. These are suggestive of biliary atresia. Direct bilirubin more than 2 mg per deciliter or 20% of the total bilirubin indicates serious disease and is never physiologic. Causes include neonatal hepatitis, secondary to congenital infection, rubella, cytomegalovirus, toxoplasmosis, or biliary atresia. It is vitally important to refer an infant with the direct hyperbilirubinemia as an emergency before irreversible damage to the liver is done. The Kasai operation, portoenterostomy, is successful more than 90% if performed before 8 weeks of life. Without Kasai operation, to drain the bile from the liver into the intestine or liver transplantation, liver failure ensure within a year and death within 2 years. The absence of a colic stool does not exclude early biliary atresia or other important causes of cholestasis. Visual estimation of jaundice may result in underestimation of TSB level. Newborn TSB level must be interpreted according to the postnatal and gestational age as well as risk factors. The TSB of infant examined before 36 to 72 hours of life is likely to continue to rise. Thank you for your listening.